Hello students, and welcome to your final lecture on hematology. My name is Dr. Kasonga, and if you have any questions, please feel free to email me or use the discussion boards on ClickUp, or you can visit me in my office in BMS 912. In this lecture, we will discuss some pathologies that can occur in your blood. So firstly, we'll take a look at iron deficiency anemia. As you should know by now, anemia is an abnormally low red blood cell count or low level of hemoglobin, or both. This decreases the oxygen carrying capacity of the blood. Anemia itself is not a disease, but rather a symptom of an underlying disease. It can be caused by accelerated blood loss or decreased red blood cell production. So some symptoms of anemia include pallor or paleness in the skin and eyes, weakness, fatigue, shortness of breath, heart problems, difficulty concentrating, and dizziness. So let's take a look at some of the causes of iron deficiency anemia. So iron deficiency anemia is one of the most common causes of anemia, and it affects about 2 billion people worldwide. Common causes of iron deficiency are an inadequate iron intake. So if you have a diet that's poor in iron, such as vegetarian and vegan diets, this can lead to iron deficiency. Poor iron absorption is another cause of iron deficiency. So if you have gastrointestinal problems, this can lead to poor absorption of iron in the GI tract, which would lead to a decrease in iron in the body. Chronic blood loss is another cause of iron deficiency. So due to ulcers or menstrual disorders, this can lead to a decrease in blood in the body, which will then lead to a decrease of iron. And then if you have an increased demand for iron, this can happen in growing children or in pregnant women when they have an increased need for iron, and if they're not getting sufficient iron from their diet, then this can lead to iron deficiency. So if we look at the progression of iron deficient anemia, iron deficiency anemia usually develops quite slowly. Due to compensatory mechanisms in the body, patients are only symptomatic if their hemoglobin levels drop below 8 grams per deciliter. Before then, few symptoms will be experienced and the condition will simply worsen. When symptoms develop, the anemia is usually quite severe and can lead to quite severe symptoms. So this is just to remind you that iron is necessary for the formation of hemoglobin. If you remember, iron sits at the center of your heme group, which sits in your hemoglobin molecule, and you need iron to bind oxygen to carry it inside your red blood cells. So if you remember, when we discussed red blood cells, we talked about iron balance. So iron can be stored in your liver as ferritin, and the majority of iron that is released from the breakdown of red blood cells is recycled to make new hemoglobin molecules. So it gets taken back into the circulation to make new red blood cells. A small percentage is excreted, so you lose about 1 milligram of iron a day, and to compensate for the small amount that is excreted, you need to get iron from your diet. So you require about 0.5 to 1.5 milligrams of iron a day in your diet. So when you have blood loss due to ulcers or excessive menstruation, the number of red blood cells will decrease, and this can affect your iron balance in your body. This results in a decrease in the amount of iron that can be recycled from hemoglobin. The iron stores in the liver will begin to be used up and decrease. With less iron around, the concentration of transferrin in the body will decrease. With less iron, the amount of hemoglobin that can be produced will also decrease, and this will lead to small red blood cells with lower than normal levels of hemoglobin, and this is known as microcytic hyperchromic red blood cells. There are several laboratory tests that can be done for anemia. You can do a full blood count, you can measure hemoglobin and hematocrit, as well as your red blood cell indices, and this can give an indication if one has iron deficiency anemia. As mentioned in the previous slide, microcytes can also indicate iron deficiency. Low levels of ferritin and obviously low levels of iron in the blood would also indicate a deficiency in iron. So why is it important for a dentist to be aware if a patient has anemia? Firstly, the severity of the anemia could result in complications if the patient is undergoing a dental procedure. To prevent complications, the dentist should assess the severity of anemia. Anemia is also associated with chronic conditions which may require certain precautions to be taken. How you handle a patient, the medication given, and the use of anesthetic must all be considered carefully if a patient is suffering from anemia. So if we take a look at the treatments for iron deficiency anemia, if a patient has anemia, they obviously have to be referred to a physician to determine the cause and to treat this cause of anemia. Replacement therapy is the most common way of treating iron deficiency. Iron supplements with ascorbic acid to enhance the absorption of iron are used. Blood transfusions can also be done in severe cases. It is also important to understand bleeding disorders, as they can have major effect on any dental work that needs to be done. So in these next few slides, we'll take a look at some bleeding disorders. So firstly, let's just take a recap of the three phases of hemostasis. So firstly, you have the vascular phase, which consists of vasoconstriction. Then you have the formation of the platelet plug, and then the formation of the stable fibrin clot through blood coagulation. The coagulation phase is then followed by fibrinolysis and tissue repair. So these images are classical signs of a person with a bleeding disorder. So these red spots are known as petechia, and they're caused by bleeding just below the surface of the skin. This large red swell is known as a purpura and is also caused by internal bleeding. So there are different diagnostic tests that can be used to determine if a patient has a bleeding disorder. So you can do a platelet count, so just count the number of platelets and see if a person has an abnormally low or a normal amount of platelets. And then you can also do different tests that can measure how long it takes your clot to form. So if your clot takes an abnormally long time to form, this would indicate that you have a bleeding disorder. So we briefly mentioned thrombocytopenia before, and this is caused by a deficiency in the amount of circulating platelets. It can result in spontaneous bleeding to occur, which can result in petechia. Petechia will usually form when your platelet count is below 20,000 platelets per microliter. So thrombocytopenia is diagnosed when you have a platelet count of less than 100,000 platelets per microliter of blood. Remember that the normal range of your platelets is 150 to 450,000 platelets per microliter of blood. So if you look at the causes of thrombocytopenia, it can be caused by a decrease in your platelet production. And this can be caused by malignant cells in your bone marrow, so a cancer in your bone marrow, or by the destruction of your bone marrow. So if you get treatment for this cancer, then it can lead to a destruction in your bone marrow, which would decrease your platelet production. Certain drugs, such as heparin, can also affect the platelet production. HIV is also known to suppress megakaryocyte production, which would then lead to a decrease in the amount of platelets. Thrombocytopenia can also be caused by increased sequestering of your platelets in the spleen. So in a condition known as splenomegaly, the spleen will become enlarged and function abnormally, and this can result in the spleen sequestering 90% of the platelets in the circulation. So 90% of your platelets will be removed from the circulation and remain in the spleen, and this will decrease the amount of circulating platelets and therefore result in thrombocytopenia. And then lastly, a decrease in platelet survival can also lead to thrombocytopenia, and this may be caused by an autoimmune disease that attacks your platelets and decreases your platelet numbers. So treatment for thrombocytopenia usually involves treating the underlying cause of thrombocytopenia. So for example, a bone marrow transplant may be necessary in some cases. Corticosteroids and folic acid have been known to increase platelet production, and these can also be used to treat thrombocytopenia. A transfusion of concentrated platelets can also be used as a treatment. And then lastly, in the case of splenomegaly, a splenectomy may be necessary. So lastly, we'll take a look at hemophilia. And this is a rare hereditary bleeding disorder. So you inherit a defective gene that results in a deficiency in one of your clotting factors. So there are two types of hemophilia. Hemophilia A, that results from a deficiency in factor 8, and hemophilia B, that results from a deficiency in factor 9. Hemophilia B is also known as the Christmas disease, as it was first described in a patient known as Stephen Christmas. Both hemophilia A and B can lead to spontaneous and excessive bleeding. Even in mild cases of the disorder, bleeding can be excessive during traumas such as tooth extraction. Hemothrisis is also a common symptom of hemophilia. This is where an individual has repeated bleeding episodes in the joints, resulting in swelling of the joints. This results in damage to the cartilage in the joint, causing the bones to grind against each other as they no longer have a protective cartilage layer between the bones. So these are more examples of joint swelling in hemarthrosis. So you can see the swelling of the joints. And here is an example of a hemorrhage that has occurred in a patient with hemophilia. So if you remember the coagulation cascade, factor 9 is an important factor in the intrinsic pathway. So if you have hemophilia B, you have a deficiency in factor 9. Factor 8 is also important in the intrinsic pathway, and it plays a very important role in the activation of factor 10, which is important in the common pathway. So if you have hemophilia A, then you have a deficiency in factor 8. So in this slide, we'll compare what happens when an injury occurs in a hemophiliac compared to a normal person. So in a normal person, after an injury occurs, the vessel will constrict and the platelets will form a strong platelet plug. Fibrin will then reinforce this platelet plug and form a strong fibrin clot, and then bleeding will cease. In a person that has hemophilia A, they lack the clotting factor 8, which will affect the formation of the platelet plug. So you'll form a weak platelet plug, and also you'll form an incomplete fibrin clot. It will also delay the formation of the fibrin clot. And this will result in bleeding for a much longer period of time and an inadequate clot that's formed, which will allow bleeding to continue. There is no cure for hemophilia. Patients are advised to avoid medications that promote bleeding and to maintain good nutrition and dental hygiene to prevent bleeding from occurring. Patients can also be administered the deficient clotting factor by IV. However, this can be quite expensive. Hemorrhages, prolonged bleeding, and spontaneous bruising are common symptoms of hemophilia. And then, as we mentioned, hemarthrosis, where you have painful swollen joints, are also a common symptom of hemophilia. So hemophilia is an X-linked recessive trait. As men have only one X chromosome, this means that the condition is more common in men than in women. For a man to inherit hemophilia, his mother only needs to be a carrier. For a woman to inherit hemophilia, the father must have hemophilia and the mother must be a carrier. If a mother has hemophilia, all her sons will inherit hemophilia. Although the majority of cases of hemophilia are inherited, a small percentage can arise through random mutations. So this brings us to the end of this lecture on pathophysiology. In this lecture, we discussed iron deficiency anemia. So anemia, if you remember, is caused by a decrease in your red blood cell numbers or in the amount of hemoglobin. We discussed the different causes of iron deficiency anemia and also discussed the iron cycle. And then lastly, we spoke about some bleeding disorders. We mentioned thrombocytopenia and hemophilia A and hemophilia B. So this brings us to the end of our lectures on hematology. If you have any questions, please feel free to email me or use the discussion boards on ClickUp.